So let's do female reproductive physiology and pathophysiology. So this is the basic anatomy. Interestingly, this has the eSure, which is a permanent sterilization device. It's actually done in the office with a hysteroscopy, passed up into the fallopian tubes, and causes permanent sterilization. The fallopian tubes obviously are here. That's where the eSure is placed. There's the ovaries. This is the body of the uterus. This is the cervix. And obviously this is the vagina. So all of this is anatomy that all of you should fully understand and have had lots of exposure to. One of the interesting things is in the old days, we used to talk about total hysterectomies, and we really only remove the entire uterus. So in the old days, we would talk about a TAH-BSO. So that's the bilateral salpingo-oophorectomy. There seems to be some shift in that. Some people now, when they talk about a total hyst, are talking about removing everything. I don't think that is as accurate as the TAH-BSO, but it is hard. We did partial hysterectomies up until the 1960s, leaving the cervix, feeling like that provided more accuracy or more normality to the vagina. Interestingly, about 6 or 8 years ago, we started doing these again because if we leave the cervix, that gives us something to actually anchor the vagina to, and decreases the risk of prolapse and other issues. So we are back to actually doing partial hysterectomies where we just remove the body of the uterus and leave the cervix intact. So it's important to understand the terminology when somebody uses that terminology, because different people mean different things. So this is the cycle. Most important thing here probably is just understanding what all the different issues or the different hormones are. So the luteinizing and the follicle stimulating hormones are the hormones that come from the pituitary that stimulate the production of hormones in the ovaries. The inhibin is a substance which has not really been talked about a lot. There's another hormone that's not on this chart called activin, and these actually activate or inhibit the estrogens and progesterones. They're not of a whole lot of clinical value at this point, but we are starting to use them as tumor markers. So for regular physiology, you're not going to worry about them, but down the road, we may start hearing a lot more about them. So normally you see that the estrogen does peak here, and then when it drops, that's the signal to the body that the ovaries should ovulate. What happens with a combined oral contraceptive is that we basically keep that estrogen from dropping. We keep it to be a consistent level. It never drops, and there's never any ovulation, and therefore the person, woman, does not get pregnant. Progesterone goes up after the ovulation, trying to produce a uterus which is primed for implantation and development of a baby. What happens in the combined oral contraceptives is that we have some progesterone just to allow the uterus to go through some kind of, cyclic or development elements, and in the triphasic, it's obviously more dramatic than in just the fixed, which will decrease the risk of endometrial cancer. You could do a combined oral contraceptive that's not combined and just has estrogen. The problem is that you would increase the risk of endometrial and maybe even some other cancers. So. And you can see the corpus luteum is the portion of the ovary that does secrete the hormone, and then it regresses if pregnancy does not occur, and that's when menstruation occurs. So all of these are estrogen hormones, and it's very confusing because there's E1, E2, E3, and E4. E2 is estradiol. That's the hormone that is the traditional hormone that most women have. Estrone usually happens in menopause, estriol and esterol. occur in pregnancy. And so they're all slightly different. As you can see, all of them have that steroid ring. We'll talk about the basic structure that makes something a steroid in just a minute. We don't usually refer to estrogens as steroids. We usually just refer to corticosteroids as steroids. Sometimes we talk about anabolic steroids. Anabolic steroids are actually testosterone analogs because the estrogen steroids don't actually promote great buildup of muscle mass. So here's the actual steroid nucleus. So basically you got this six-sided ring, another six-sided ring, another six-sided ring, and a five-sided ring. And anything that has that basic structure is a steroid. And so corticosteroids like cortisol have this, but so do testosterone and estrogen. So again, here's just a review of what the various estrogens do. The estradiol is the one that is the normal one that cycles estrone predominantly for menopause. Estriol and esterterol are pregnancy hormones. So the estriol actually has very little action on the endometrium. This is the pregnancy hormone. That makes sense. It just allows it to enlarge, but the cervix and the vagina and the vulva will actually change some. Estrone is an interesting hormone because it goes up during menopause. We synthesize it from the urine of pregnant mares. That's where the drug Premarin, pregnant mares, Premarin comes from. And also the Mexican yam actually is another source of estrone. We use it in women that have low ovary function after a ovarian removal for associated with a hysterectomy. If they've got symptoms of menopause, men that have prostatic carcinoma, if they're not candidates for some of the other treatments, sometimes we do use estrogen to stop the growth of their cancer and block the testosterone effects. We'll often remove the testicles at the same time. This is a very old treatment. We rarely use it anymore, but it is still an option. And in women with abnormal uterine bleeding, sometimes we'll use the estrone. And the estradiol, as we note, is the usual. It's important to remember that the endometrium, the inner lining, also has other functions. So it produces prostaglandins. We can block over use of or over development for menstruation by using an anti-prostaglandin such as ibuprofen. But there's leukotrienes, there's interleukins, there's all sorts of things. So when we remove the uterus, we do remove a source of some of these hormones, and this would be an argument for not removing the uterus. On the other hand, many women are afraid of cancer or are sick of having heavy periods and are more than happy to get rid of their uteruses. And again, so the ovary does not just secrete estrogens, it also secretes progesterones and also androgens. Androgens are also secreted by the adrenal glands as well, but women do produce testosterone type hormones. This is usually what results in sex drive in women is a higher level of androgens. And that's why sometimes we'll actually use testosterone type medicines in women if they have concerns about their level of sex drive. And again, estrogen is not recommended for women with a history of breast cancer, especially if it was a history of an estrogen-sensitive breast cancer. Coronary heart disease, the Nurses' Health Study gave us very conflicting information in regards to whether estrogen is good or bad for heart disease, but we tend to err on the side of caution and not give it to women that have heart disease or have had stroke. We do know that the adverse event risk is very low. Generally, if a woman does still have her uterus, we're going to add some progestin, and it has caused endometrial cancer pretty quickly in some women. The progestin should not be added um, in women that have had a hysterectomy. So you just give it in the women that have had a hysterectomy. Um, and again, you can use these hormones for 2 to 3 years. We don't recommend more than 5, but some women do insist on staying on, and the risk is real but modest. You can use systemic estrogen. You can do that orally or transdermally. We sometimes use a localized estrogen too, with an estrogen cream that we use intravaginally if the woman does have problems with what we used to call atrophic vaginitis, but we now just refer to as an atrophic vagina. And again, the Premarin is mostly estrone. Vival is actually estradiol. So there's various preparations of hormones. The estrogen, will cause women to gain weight usually. They may have some belly pain, change in mood, all of these things if the estrogen is too high, especially. Combined oral contraceptives, as we talked about, basically keep the estrogen level from going up and then dramatically dropping and stop ovulation. We know that they have benefits and risks. We know that the risk of venothrombotic embolism is about 1 in 5,000. But we also know that women that are on oral contraceptives, if they're on it for 15 years, their risk of ovarian cancer is half what it would be otherwise. So they have risks and benefits. Vaginal estrogen for vaginal atrophy. And again, we use it topically. There's various preparations of it. Can have side effects, although they're pretty rare. Sometimes we'll use a compounded estrogen, and so you have to find a compounding pharmacy. It can have estrone, estradiol, or the pregnancy type hormones. You can try different percentages. They often have recommendations, and sometimes you'll even put a little bit of testosterone in it, again, to help the woman's sex drive. In 2006, the PCOS Society changed the criteria yet again. Polycystic ovary syndrome is pretty common. If you see a woman that has sort of a pear-shaped body, has a fair amount of body fat, maybe has a little bit of thinning of her hair, has very irregular periods, may have had some problems with infertility. The vast majority of these women are going to meet the criteria for polycystic ovary syndrome. Interestingly, you do not need to have polycystic ovaries to have polycystic ovary syndrome. But you do have to have evidence of excess androgenic activity, evidence of abnormal ovulation, as well as usually the criteria with hirsutism, distribution of body fat, and the various usual elements of the PCOS syndrome. The Rotterdam criteria preceded this PCOS Society criteria. Some people still use the Rotterdam criteria, but neither one of them require polycystic ovaries to have PCOS. So here's the pathogenesis. So lots of times in PCOS, you see that the weight increase and the insulin resistance may actually precede some of the other problems. And we see that insulin increase decreases IGF-1, which actually will increase testosterone, and then they may have a slight increased risk of endometrial cancer, so they do need to be very carefully followed for that. We also see that the insulin increase, which increases appetite and therefore increases weight, will change the sex hormone binding globulin, which also increases free testosterone. So lots of these women will get excess hair. They'll have weight abnormalities. It is a pretty complicated condition, even though some estimates it's like 15 to 20% of the female population does meet the criteria for PCOS. So again, just to review that if you're using supplements, there's lots of different variations. The progestins, the medroxyprogesterone is Depo-Provera. We use that as a contraceptive in women. It will decrease ovulation or eliminate ovulation. It also is used sometimes if a woman is overdue for her period, you're sure she's not pregnant. Sometimes we'll do that. A lot of the other ones, if you look at combined oral contraceptives, they often have either norethindrone or levonorgestrel or drospirenone in them. And so they're all slightly different. These are more testosterone-like, and so depending on whether the woman is having excessive bleeding or decreased sex drive or whatever, you can actually alter that oral contraceptive, look at the type of estrogen that's in it, and look at the type of progesterone in it, and you can usually get rid of the side effects. Note that spironolactone is over here. Usually we think of spironolactone as a diuretic. We give it as a medication. It is predominantly used as an aldosterone blocker or an aldosterone inhibitor, and therefore will cause fluid to go out of the body. But note that it also is something that is used as a hormone. There is another aldosterone blocker, eplerenone, which is a pure aldosterone blocker. It doesn't actually have the effect on the hormones, but the spironolactone often can also block testosterone effect. We use it for PCOS as well. Fibroids are benign tumors, obviously occur usually somewhere in the body of the uterus. You can have very enlarged areas. Some of these women, especially if they're down near the endometrium, will have excessive bleeding associated with them. They will usually regress after menopause. We haven't really got a great understanding of why they occur. We do think that there is a gene that is passed, and so it does seem to run in families. There's also epigenetic effects, we think. We think that there's a hypomethylation of ER alpha, and that therefore you may see it run in families for that reason as well. Estrogen and progesterone tend to affect it, but it also is something that's affected by tumor necrosis factor alpha and the interleukins. So we really don't have anything that will translate into any sort of treatment for it, but down the road we may be able to have something. It's also, I think, very interesting. It'll be interesting to see if all of the monoclonal antibody medicines that we use now for TNF alpha and interleukin 1 and interleukin 6, whether those actually have any impact on the frequency of fibroids, and whether they may even result in some epigenetic changes which may be passed on. So this was kind of a quick and dirty explanation. There's obviously a lot more to it. You'll learn more as you go through your women's health rotations and things, but I think this gets you started. So we'll do men's health and GI for this week as well.